primary healthcare agencies, state health insurance agencies to deliver efficient, equitable, quality, and trusted services through functional primary health centers that are accessible to all. We will work with you all and our other government partners, including the National Center for Disease Control, to ensure early response, detection and response to disease outbreaks, like I said. Our goal for the primary healthcare system is to ensure that every Nigerian, wherever they are, have equitable access to good quality and trusted primary healthcare services. That's a loaded goal and has many different components, but almost every single part of that has a major role for the faith community to play. That is to the people, but very importantly, engaging with the communities that they serve in a way that reinforces mutual trust, so that the communities know that you are there to serve them and they engage with you in a way that in a new way, basically. I think we understand what I am talking about. So we will be doubling the number of fully functional, actually, we will be increasing the functionality of facilities across the country. Many of the current facilities don't meet the bar of functionality. We will be increasing that. About 8,800 facilities today receive direct funding from the government through the basic healthcare provision funds. Over the next 3 to 4 years, we will be doubling that to 17,000. But working PHC by PHC, we want to make sure that each of these, beyond receiving the funding, the operational funds that they need to provide services, that they have all of the elements that makes them fully functional and dependable for the communities that they serve. Again, this is something that our faith-based partners have done for years, not at the scale that government is trying to do it, but there's a lot to learn from what you have done even for us. You know, each of the PHCs will be linked to a secondary facility that will then provide the more comprehensive emergency obstetrics and newborn care, basically higher level of care that require referrals. So we also have a referral mechanism, and we're investing in building even a transport system to connect our people from those primary facilities to those secondary facilities. To address the dearth of human resources for health, which is a major challenge for us. I always tell people that if our donor friends give me a lot of money, I can build primary health centers. There are a lot of contractors. I can buy basic equipment for them to use, but I cannot manufacture health workers. And a nice fancy building that is well equipped with no health work in them simply gets vandalized. That's what happens to it. So if you ask me, that's the biggest bottleneck. Money we can raise, people we can't produce overnight. So we're working very hard. A lot of our training schools are either faith-based right now or in fact started as faith-based. So again, there's a big role, you know, in terms of your collaboration with the faith-based community in expanding the production capacity of our training institutions, in creating incentives and aligning policies that will increase retention of the health workers. Because in addition to not producing enough and not being able to pay them enough to retain them, many African countries today are contending with very mobile health workforce, where most competent people simply are living in droves for many, many different reasons. So there is a set of interventions that the government has put in place to try to address those. That includes, you know, a retraining of about 120,000 frontline health workers, which we're working with the states to kickstart in a few weeks. Basically, these are people who are working in the front line, many of them have either never been actually received any in-service training since they were hired, and those who have not received any in 15 years. So at least can we quickly equip them with the basic skills they need today in the post-COVID world to take care of the conditions that are pertinent to their societies. Following that, we are going to be investing in more sustainable continuous improvement mechanism for them, while we're also focusing on increased production and retention of these healthcare workers. We are confident that our vision, as encapsulated in the blueprint, will set the country on the path of making incremental progress towards achieving UHC goal. And we are determined and in fact committed to collaborating with all of you to positively impact the health and well-being of our people. We therefore urge Chan and all well-meaning Nigerians to join us in the journey to the transformation of our health system. Colleagues, Your Excellencies, distinguished ladies and gentlemen, I wish you a very fruitful deliberation and really look forward to the outcomes of this. I'm taking a cue from my friend the WR, and if you permit me, I will also ask a couple of colleagues, see who we can pull out from all of the many ongoing activities to join you in the deliberations today, so that you can also hear from us, but also we can hear more directly from you in the course of the deliberations. I hereby declare the 11th Biennial Conference of the African Christian Health Association platforms open to the glory of God and for the benefit of mankind. Thank you. Professor Mohammed Ali Patel.
Thank you so much, the Honorable Coordinating Minister for Health and Social Welfare, for what the government is doing and for the support we've given to the faith community, and for this particular conference for declaring it open. We are excited to always have you, and we understand how busy your schedules are, so we will excuse you too. It's in our power now to bless you and excuse you. But before you leave, I've been asked to kindly request a quick photo with you. The minister's representative, the board of ACHAP, partners, our keynote speakers, and the chief guest. Quickly to the podium so that we can save time. Then after now, we're having another general group outside, photo outside the entrance of the hotel, please. Yes. And then after all the photos, we now have a tea break, health break. Partners, please. Partners. You call them. Eh?
Executive Directors of CHS, kindly.
Yes.
Dr. Tony. And our partners. Corey, you might want to organize us into more than one row. We proceed outside for a group photo, outside the hotel for a group photo, then come in for tea. And after tea, we have a plenary in here. We proceed for a group photo outside immediately, kindly.
We'll take a short time. We'll take a short time to move out. Please kindly step out for the group photo. We We are going to take less than 5 minutes to take the photo. So when you're not there, we'll just take the photo. Please find your way out, kindly.
You say you get what you want me to do.
You know, I can't access
Okay, so what would I do?
just a small graphics. We'll be right back. Tea break or something. Just give information.
Let's move to that group outside. Please, kindly. We'll do more introduction. Let's kindly move to the group. Raise your Monene. Children, we don't have screening at the moment. Please let people move out for and
Hello. Welcome back from our tea break and from that very exciting entertainment. Indeed, we have had a very rich morning, beginning with building the faith foundation and those very powerful opening remarks that we've heard from our key stakeholders and from government and WHO as well as USAID. So now we want to get back to diving deeper into UHC. So my name is Dr. Sam Mwenda. I'm a member of the board of ACHAP. I come from Kenya. I'm the General Secretary of Christian Health Association of Kenya. It's indeed a privilege and an honor for me to briefly moderate this panel session. I've been consulting with the organizers and leadership of ACHAP because we realize we are way behind time. We also do recognize that we've had quite rich, sharing from both WHO and USAID and the government. We feel it will be possible for us to combine two panel sessions. One which I'm moderating, having some of our international partners to share their perspectives about universal health coverage, but also we have country experiences, which will be the next panel that Dr. Josephine Barati, our Vice Chair for ACHAP from Tanzania, will be moderating. So in the interest of gathering as much perspectives as possible, but also cognizant of the need to allow you, our delegates, to engage with the panelists. We will save on time by combining those two. And in our program, you have a bit of detailed information about our panelists and presenters, so I'm not going to take much time introducing them. But for this particular session, we will have brief presentations or remarks. We have with us the President and CEO of Corus. He has been with us in this conference since we started. So we'll be hearing from him about some perspectives about North to South collaboration, and he's here, he's ready. USAID has been very gracious. They have sent us Sylvester Akande to share on, to give us further perspectives on localization and how it's contributing to universal health coverage. Also in various countries as they support us. And he is here and he's ready. Welcome, Sylvester, and thank you for accepting to join this panel. We've already heard so much from the government of Nigeria from those very high-level remarks. Michael will advise, if we do not have the moment as someone to join that panel, I think there's going to be a team with us as we've already been informed, so they'll be joining our discussions in the various groups. So that will be the first panel. And as we finish with them, before we get into the question and answer session, we will go into, I'll ask Dr. Josephine to come and introduce the rest of the panel, a number of us from different countries, to briefly share perspectives from what is happening with UHC, what initiatives are policy level implementation, reforms, and so on, but also specifically what faith-based are doing as a key stakeholder in contributing to the attainment of universal health coverage. I want to believe, Daniel, you're ready? Are you ready? Yeah, if you don't mind, you can take the podium and just share with us a partner perspective. Yeah. Well, there we go. You can take it up there. And as when he finishes, Sylvester, we will request that you get ready. I know you have some slides, and you'll be ready to project them for you.
If I can move around a little bit, it'll be easier on you and easier on me. Also want to thank USAID for being part of this. If you don't know, Ariella is well known in Washington, D.C. She is one of the key authors of a lot of what's being done in localization and really leading the charge for that for USAID. We're really proud of the work that USAID is doing in this area and that you made this trip out here to be part of this. And Katha asked me just to talk very briefly from the perspective of an INGO about localization. And so I just wanted to highlight a few things from our perspective. And that is that, first of all, that this needs to be part of all of our DNA, right? It's not about INGOs or local NGOs or local faith-based organizations and international ones. This is about the people we serve, right? And I think if we sometimes forget that at the end of the day, it's not just about turning international NGOs into local NGOs and creating mini-me's and having federations of all this kind of stuff here as if we're just kind of going the next iteration. This is about, at the end of the day, how do we put the dignity of the individuals that we're serving, right? You're a local NGO, you're a faith-based NGO, you're a national NGO, but at the end of the day, you're about listening and understanding and respecting the people you're serving. This is what our faith brings to this, right? Our faith brings to this idea that every person has this dignity under God, whatever your faith is. And so that's what inspires us at Corus International to think about this issue and to try to continue to strive to do a better job at that. We have been doing this for about 30 years. We've called it accompaniment because to us it means not, we talked yesterday about capacity building. It's not just about I come from the United States and have some ideas on how to help you develop your capacity. It's about how I come here and listen to what you are facing, the challenges that you are struggling with to implement and execute and undertake your programs. And then I take that back and we think about what do we know about all the experiences in the world that are happening? What kind of technical knowledge can we bring to bear on this? And then how can we share ideas with you on what we found works in other places? Or perhaps we can bring additional resources and technical support to this. So for us, this idea of two-way accompaniment, shoulder to shoulder, is to me one of the most important principles of this. And I'd like us to avoid getting in this mode where it's about us providing you capacity, right? Health is a global issue that doesn't respect borders, right? These aren't nicely contained things that each country has its own diseases. They cross across all these borders. So what you're learning here in Nigeria or Malawi or Tanzania or Sierra Leone is really important to American health, to European health, to Asian health. And so we have to really look at this in a way that understands that what we're talking about is capacity building in both directions. And we need to understand a lot better what these challenges are that you're facing as you try to do health in your countries. What I'm amazed at is how resilient you are as leaders and as executives of these different organizations, and how you continue to innovate and use ingenious new opportunities and techniques to figure out how to problem solve. It's not about resources at the end of the day. Resources can make a lot of difference, but it's actually not. It's about thinking differently, thinking outside the box. And I know where I can benefit the most from you, where Corus can, all the international NGOs, is you are the ones that have to innovate the most because we have more resources, right? So we don't have to change the way we're doing things. But for you guys to be successful, you're going to have to do that. And Katha also asked me just to say a little bit about why Corus is a little bit different and how we're thinking about this. We do have to think differently about what INGOs are going to do in the future. What's the role of an international NGO? And I think as we think about it, we think about the idea that part of the challenge with international foreign assistance, part of the challenge with local governments, national governments, and others is we stovepipe ourselves. So we have the health ministry, we have the agriculture ministry, we have the environment ministry, and they're all about doing their own job. But we forget that these things are all interconnected, right? And that to have a healthy community, you have to be addressing issues like incomes for the local populations, that they have jobs and employment for young people. that you have to deal with the issues of environment, whether there's floods or droughts or whatever else that's going to affect their health. And so at Corus International, what we've tried to do is think, how can we help contribute to solving these problems? And we've decided that we can't just be a health agency or a rural development agency or a technology or an education agency. We've got to bring all these things together. So several years ago, we did a merger, and we have a global health organization that's 60 years old that you all know well, IMA World Health. We combined with Lutheran World Relief, which has been doing rural development and livelihoods work for 75 years. We then added an education group in the technology space called CGA Technologies. And then we realized we needed to be part of the global economy if we're going to actually really help people. So we brought in some businesses. We brought in impact investing businesses, that is actually investing in businesses in rural areas. Most of the time these people like to invest in Lagos, but they don't like to invest out in the very difficult places. But these communities are not going to become healthy if there is no business, no activity, no economic things going on. And similarly, we opened a direct trade company called Farmers Market Brand, because what we found is all the middleman between your country's producers and the consumers in the world are taking all the profits and nothing's getting back the subsistence farmers, where many of those poorest communities are involved. So the idea here is, how do you bring all that stuff together and try to do it in a more holistic way? I hope actually you as CHAs are thinking the same way, thinking about what it takes to actually really provide health beyond just providing health services, because you need to be advocates. Even if you're not thinking about expanding into these other areas, you need to be advocates for that, because the reason health isn't growing as fast as you want it to is because these other activities are not occurring. People don't have the livelihoods, they don't have the resources, they don't have the education. The environment is failing them. So I hope that you will all kind of consider how to take a more holistic view of this. I'm going to close just by saying again, I am so honored to be with you. I mean that. This is an incredible group. When you think about how many lives you are touching in this room, it's an amazing responsibility. And I am just so impressed how humble you are when I meet each one of you, the humility you bring to the table, and the passion that you have for making this world a healthier, more dignified place. I can promise you that our role as an international NGO is to support you, to find ways to help you, to be your advocate back in Washington. Ariella is your advocate, I know that, but she knows as well as I do there's a lot going on in Washington beside what we care about. And what happens is, when Ukraine blows up, when the Middle East blows up, all the resources that were going to come to us for health and to work together on this stuff start to shrink. So I hope you'll also see that international NGOs aren't here to try to do your job. We're here to try to connect you to the international community. And that community is losing attention on things that are absolutely essential to the future of this world. And that's the stuff you're doing, and the health and the welfare of an entire continent. So I want to promise you that the most important thing I think we can do as international NGOs is be your voice, see you as our partners in the international community, and take your messages back. So the reason I spent 3 days here is because I want to be listening to all of you. I'm not here to give a speech, I'm here to listen. So thank you very much.
Big hand to Daniel. Thank you very much for your friendship and partnership, for all the advocacy you're doing for us, but also that commitment. I like the statement about two-way partnership, shoulder to shoulder accompaniment. Sylvester, are you ready to come up, please? Yes, welcome. So Sylvester from USAID is going to give us perspectives about localization and how that is supporting journey towards universal health coverage. Please set it up for him.
Can I? Good afternoon, everyone. It's afternoon, right? Again, just like Daniel, I'm really honored to be here. It feels like homecoming for me. You know why? 17 years ago, I was volunteering for Chan. And here am I, 17 years after, and that was the USAID project. It was called the Nigeria Indigenous Capacity Building Project. Anyone knows that here? NICAB, 2008-ish. Dr. Zipporah Pamo was the then project director, and I just finished my NYSC. So I spent the first 3-4 months with them, after which my career took a flight. And 17 years after, I'm here representing USAID, speaking to Chan and other affiliates. So you can understand how I really feel honored to be here this morning. Are we ready with the slides? So, it wasn't Nkatha that asked me to speak, it was Dr. Samuel. So, I'll be speaking to enhancing access and coverage for universal health coverage through localization. So, if you look at the world that we live in today, there are so many dividers and very few connectors. And I make bold to say that the pursuit of universal health coverage is one of the biggest connectors we have in the world today. Almost every world leader chants universal health coverage. Many of them have gone beyond the rhetorics to also put in place plans that will move their countries and governments in that direction. There is hardly any health forum that you attend today that UHC is not discussed. And so when you think of that alone, you could say we're in a good place. That yes, there is an agreement worldwide, the direction that we should be taking. However, it has not all been a runaway success. So it's not enough to have solidarity for UHC. I think the question to be asked is, how well are we doing in terms of meeting the targets that are before us? And I believe both the WR and Dr. Muyi mentioned this, that we are off track. And just to share a couple of statistics, using again what's called the UHC Service Coverage Index. The world today is at 68 out of 100. That's the world. But Africa is at 44. Nigeria is at 38. 2030 is just 6 years away from now. And frankly, we are not on track. And unless something drastic is done, those targets will not be met. So, I did say that many governments have translated the commitments they had into strategic plans, but still there are many implementation challenges. Because of these challenges, there are still issues that persist. Issues of access, issues of quality, issues of coverage, and of course, financial risk protection. In Nigeria, for instance, over 46% of women still have resource constraint issues to accessing the much needed services. Quality of services still remains an issue. In fact, a recent Lancet publication did say that in the world today, quality is actually more of a problem than access. So folks may be having access to services, but the quality of services they are getting is not one that leads to desired outcomes. So again, because of these implementation challenges, quality remains an issue. Coverage, if you ask anyone in Nigeria, and depending on what data you're looking at, you would get between 4 to 6% in terms of the proportion of the population that is covered under a financial risk protection scheme. When you think of that figure, it still leaves a lot to be desired. Out-of-pocket expenditure as a proportion of total health expenditure in Nigeria is still over 70%. And if you know a thing or two about what is going on in the country today, you realize that with this sort of economic situation, it puts people in even much more difficult situation to access health services that they truly need. Of course, the implementation challenges further perpetuates the poor health outcomes that we have. And for Nigerians who know a thing or two about our statistics, this is not new to you, right? But then when you look at what's on the right, we're not in good company. When you're looking at the bottom 5 in terms of maternal mortality, infant mortality, life expectancy, and including under 5 mortality rates, That's where you find the country. That's not a place where we want to be. And everything Dr. Muyi talked about is in response to getting us out of this conundrum that we are in. If you look again at the other statistic there, the country is again in the bottom 10 when it comes to total fertility rate and stunting prevalence. But there is good news, and that's what I'm getting to. So the challenges that confront UHC implementation, it's true that they are diverse, they are complex, it ranges from socio-cultural to economic to political dynamics, all of that. But bottom line is that those challenges are local. Challenges are what? The challenges are local. But that's not even the good news. The good news is that the solutions, right, that are available to address those challenges are also available locally. And so that's why I've put it there that, yes, it's local challenges, but then there are also local opportunities to address that. And I put a quote there from the USAID administrator, Samantha Power, when she said, if we truly want to make aid inclusive, then local voices need to be at the center of everything we do. And so if indeed there are local solutions to these problems, then indeed, you know, folks like everyone in the room today, from Chan to Chak to Chaz, you know, to all the athletes across the countries who are local actors, faith-based organizations, need to get their voice heard, you know, and not just their voice heard, they also need to be at the table in supporting the design, implementation, and monitoring of UHC efforts. Moving on, this is what USAID has committed to, because again, after years of implementation experience, it is clear that these solutions are available locally. And so USAID, and I'm sure Ariella hinted at this during her remarks, USAID is committed to shifting funding, but this is not just about funds alone. It's also about decision-making power, first and foremost to the people, to the organizations, which of course includes faith-based organizations like everyone else in the room, and institutions that are driving change in their own countries and in their own communities. So again, this is basically around ensuring that this is locally led development, you know, that is being run by those who are on the ground, who know the context, understand the issues, and really do know what the solutions are. I don't know how many people are familiar with what's called the African Collaborative for Health Financing Solutions, ACS. This is a USAID implemented program. It's closed out now. It closed out in 2022. It was in 6 countries: Botswana, Burundi, Rwanda. I'm not sure I remember the other 3, but this was implemented in 6 countries. And after 5 years of implementation, they made a note of some of the lessons that will be very critical in advancing universal health coverage. And you'll see that I've emboldened 2 things here. One of it is local ownership, and the other is involvement. And when I use the word private sector here, that of course includes the faith-based community as well. But in addition to those 2, those other points that are there are also very important. Collaboration, multi-sectorality. I think it was Dan who mentioned it here. It's not just about health. When you're talking universal health coverage, a lot of us think it is simply about health, when indeed there is a financial aspect to it. A good friend of mine will say, oh yes, while health is a social issue, it has economic consequences. It takes a lot to provide access to quality services to an entire population. And if you're not having conversations with those who control the purse strings, you might as well be building castles in the air. Nigeria is over 200 million people. You know what it would take to provide services to everyone? To ensure that the over 40,000 PHCs are fully functional, they are staffed, and these facilities are getting essential medicines and commodities as I went due. It couldn't just be a conversation that would happen within the health sector. It has to clearly involve the central budget MDAs. They are not the only ones that should be involved, but I'm just picking that as a very good example. Of course, accountability mechanisms as well as community participation. But what does this really mean in practice for USAID and the way that we work to put locally led development at the forefront of the things that we do. One will be around supporting local organizations and strengthening the UHC ecosystem. I just talked about why it's important to have the Ministry of Finance at the table, but they are not the only ones. I know the Chan folks are here, but I'm not aware that Chan is in conversations at the national level with the Health Financing Technical Working Group that is driving UHC efforts in this country. So we'll commit that as we're supporting the government of Nigeria. Part of what we'll be doing is to expand that ecosystem for UHC and ensure that critical folks like the faith-based organizations are also a part of this. At the state levels, there are health financing technical working groups as well. Again, I've had experience working in a lot of states. In so many of them, faith-based organizations are not necessarily at the table. I think we need to make deliberate efforts of bringing, the faith-based community into those conversations where the roadmap and the plans for UHC implementations are being discussed. Second point, if we truly want to make progress on universal health coverage, we cannot but consider very deliberately the issues of learning. And when I say country level learning, it can be country to country. I just talked about the ACS project that worked in 6 African countries. And by the way, the implementing partners in those countries were all local organizations, 6 local organizations. AMREF, I think, was part of it. REMSA, and I think 4 others, all local organizations. On that project, it really helped to have cross-country learnings because, like Dan said, the problems we face while they are local, to be very honest, they are very similar across countries. And the solutions can also, be transported to elsewhere. But beyond country-to-country learning, in a country like ours, where it's a federating system, we've got 36 states. Those 36 states are frankly like countries. And there are learnings, again, that can be taken from one state to the other. And that's part of what we've been doing. And there is no better, community to drive this than first the local actors as well as the faith-based community. Again, just so that you know, and I think Dr. Muyi hinted at this, there is a huge, trust deficit in the country just because of people's experiences. They show up at public facilities, they could be on strike, there are no drugs. I was just telling Ariella my story. In my final year of medical school, I was involved in a car accident and I had a head injury. And I was in coma. Guess what? They rushed me to the teaching hospital where I was being trained and they were on strike. So they couldn't attend to me. I would have died. This was in Jos. The only hospital else that they could take me to was Our Lady of Assumption Hospital. I think it's called Ola or so. And a few days later, I was up and running, and here I am today. So in a country where there is a lot of trust deficit for public facilities, this is where the faith-based communities come in, right? Many of us trust these hospitals. Many of us know that if you go there, it would be affordable care. They wouldn't overcharge you, as it were. And so when we're talking about learnings, I'm sure that's what Dr. Muyi was hinting at, to say there is a lot to learn from the faith-based community on how they've ensured that decades, you have remained at the forefront of delivering quality, affordable, and accessible services to the populace. The third point here, in terms of what we can do with local actors and to put them at the forefront, is generation of evidence for health financing decision. Yes, you want to cover 200 million people, as it were, in Nigeria. I just talked about how that would cost, significant resources. If you go to a governor today, if you've ever had the chance to speak with either a governor or a political leader, like I said, there is solidarity behind UHC. Many of them know of the benefits of UHC. The benefits cut across just health. It's got, economic benefits, political benefits, and all whatnot. The question most of them ask is, where will the money come from? Right? These are states that are struggling with wage bills. Many of them are struggling to pay salaries. They are